Why don't we go ahead and start?
Good morning, everyone. Welcome to our Monday Grand Rounds, and it is my honor and privilege to introduce Dr. Yair Blumenfeld, who really probably needs no introduction. But Dr. Blumenfeld is a professor in the Division of Maternal Fetal Medicine and Obstetrics in the Department of Obstetrics and Gynecology. His clinical focus is management of high-risk pregnancies in the outpatient and inpatient settings, including comprehensive prenatal, intrapartum, and postpartum care. He is the director of fetal therapy at Lucile Packard Children's Hospital, Stanford, and serves as the fetal therapy domain lead for the Dunleavy Maternal Fetal Medicine Center for Discovery, Innovation, and Clinical Impact. Dr. Blumenfeld's interest in prenatal diagnosis and fetal therapy was apparent since his fellowship days at Stanford, where he worked closely with Professor Stephen Quake in the development of the technology which underpins cell-free fetal DNA screening. He also spent time as a young Stanford faculty member at Texas Children's Hospital, working with Dr. Michael Belfour on fetal surgery and developing those surgical skills and bringing them back to Stanford. He has been involved in multidisciplinary clinical and translational research for over 15 years at Stanford, with a focus not only on prenatal diagnosis and fetal therapy, but also clinical obstetrics and prematurity. And as such, he really represents the phenotype that we have here at Stanford in maternal fetal medicine and obstetrics of a holistic approach to obstetrics. He is particularly interested in novel technologies and device development to improve treatment in the areas of prenatal diagnosis and fetal therapy. Dr. Blumenfeld has more than 100 peer-reviewed publications. He is a reviewer for multiple obstetrics and gynecology journals and is on the editorial board of the journal Prenatal Diagnosis. His research is supported by multiple funding mechanisms, including the NIH. Today, he will be talking to us about development and validation of a novel fetal vesico-amniotic shunt, the Vortex shunt. Welcome, Yair.
Thank you so much, Yasser. Oh my goodness, you only left me 40 minutes for the presentation, but really appreciated. And I think talking about the phenotype of MFM, clearly you and other senior members of the division really set the sort of blueprint on what an ideal MFM ought to be. And specific for this talk, even though it's fetal therapy focused, clearly my passion and interest in prenatal diagnosis and fetal therapy didn't come out of nothing or out of the air. You know, there was a very strong track record here, starting even with Usha Chitkara, who came here with Maury and was always sort of the fetal person to his maternal counterpart. And over the years, between you and Deirdre, and certainly Jane, who I want to mention as sort of the mentor in the fetal realm, and certainly related to this talk in the management of ludo and pleural effusions where we use these shunts. So with that said, thank you again for this wonderful introduction. Let me share my screen and start. Hopefully everybody can see this. And so this talk is obviously focused on a rather, I don't want to say esoteric, but certainly an uncommon fetal anomaly. But I wanted to present this, one, to let you know some of the things that we've been doing here that are not necessarily clinical oriented, or at least originated from a clinical need, but certainly a little tangential, and really to sort of highlight the types of multidisciplinary endeavors that would only be possible at a place like Stanford, and certainly the reason why many of us, and myself included, choose Stanford as our home, so that we can be involved in these kind of endeavors in addition to the clinical care that we provide to our patients. So with that said, let me start. I have no financial conflicts of interest to disclose, but related to the shunt that we developed, Stanford did submit a provisional patent. And as you'll see, given the incidence of the disease, nobody's going to be gain significant wealth out of this. This is truly a passion project. These are the learning objectives related to this presentation. I think everybody here on the call who can recall embryology, certainly our REI colleagues and MFMs are aware of this, that the kidneys develop quite early in gestation. And this is the only embryology slide that I'll have on this talk. So to all the trainees, don't worry, this is it. But the point is this: we can really see them even on first trimester ultrasound, and actually in our PDCs across the region. It is an organ to be checked off if you see it in our first trimester ultrasound. So we actually make an attempt to see them as early as 10, 11, 12 weeks. But renal anomalies are actually one of the more common anomalies that we see after cardiac, but overall they're quite rare. Certainly the more severe ones are quite rare, the ones leading to renal failure. And in utero renal failure, what we mean is kidneys that stop functioning for a variety of reasons while the fetus is still inside, have certain etiologies. And you can see those here. And I won't talk about the other etiologies, but we'll focus on this sort of basket of diagnoses called lower urinary tract obstruction, or LUDO. And in the image on the right, what you're seeing is a fetus here. And these are actually our multicystic kidneys. And you can see there's no black area around the fetus, so there's no amniotic fluid here. So there's an example of fetal renal failure from cystic renal disease, not from LUDO, but just to highlight the different etiologies. And so fetuses with in utero renal failure, and certainly once they're born, this is a significant disease that leads to a significant neonatal morbidity and mortality risk. And as our colleagues have perfected their techniques for the care of neonatal renal failure, meaning a neonate that is born, and they're able to manage the renal failure with early onset neonatal dialysis, and a lot of advancements in that field. What we're seeing is more and more morbidity and mortality being driven by in utero abnormal lung development. So it's really the anhydramnios, which leads to abnormal fetal lung development, that is really the culprit here as neonatal renal care has developed. And we're not really sure what the precise mechanisms are. Certainly there's some extrinsic compression component, but it's really the molecular underpinnings on the interplay between the amniotic fluid and the lungs that we don't quite know. And there's a lot to be learned there from a biological mechanistic standpoint. But something, when the fetus has anhydramnios prior to 20 weeks, and you're talking at these very earlier gestational ages of lung development, that this canalicular and saccular and certainly the alveolar phases of lung development are severely diminished, and these babies essentially are delivered and then pass away within the first 24 hours of life. When you have anhydramnios, there's obviously concern for umbilical cord compression. Oftentimes we have iatrogenic preterm delivery when we see cord compression and its effects on the developing fetus, and not an insignificant risk of cesarean delivery, oftentimes because these fetuses are in breech presentation, and obviously you can't perform a external version, or because of concerns with intrapartum monitoring in the setting of anhydramnios. Again, a lot of development in postnatal renal care. It would take another at least 1 hour lecture and outside of my scope of expertise. But I just want to say that historically, the way neonates were dialyzed is vis-a-vis something called peritoneal dialysis, where these catheters are placed in the abdomen of the neonate. And in terms of the size limitations of this technology, the neonate needed to be, in most centers, about 2.5 kilos. Advanced centers, maybe 2.2 kilos. Really, cowboy centers was 2 kilos. And that actually, as we were performing some studies, particularly the RAF trial, which I won't get into, but this becomes very important, because many of these fetuses are growth restricted, and there's a fair amount of preterm delivery. So if you have a preterm delivery of a growth restricted fetus, all of a sudden 2 to 2.5 kilos becomes the difference between life and death, because if the neonatologist can't dialyze these neonates, then it doesn't matter what the lung development has been. And what we've seen, certainly over the last 5 years, is a modification of sort of the way we think of adult dialysis, or hemodialysis. And there are two new modalities where cannula inserted into the large vessels of a neonate, and they certainly undergo not just peritoneal dialysis, but hemodialysis. And that's really lower or decrease the threshold in which these neonates can survive with in utero renal failure. Now many centers can actually start dialysis at a weight of about 1,500 kilos, which really has been a life-saving measure. And again, just highlighting what a peritoneal dialysis sort of looks like over here when you can see it through the peritoneum. So clearly a significant disease. And so it makes one wonder, is there a role for fetal therapy? Can we alter the natural progression? Can we really improve lung development? And really, what are those conditions and who are appropriate candidates, both fetal and maternal? And so talking a little bit about Ludo, or bringing everybody up to speed, Ludo is not a diagnosis, it's an ultrasound finding. And essentially it's an obstruction somewhere in the distal urogenital tract, more common in males, but that's because the majority are driven by something called a posterior urethral valve, where there's a small membrane at the bladder outlet. And this is more common in male. And it's so common that historically people said, oh, they didn't use the word ludo, they used a posterior urethral valve, presuming this is a male fetus. And what we know now is there's quite a broad differential diagnosis, including anteurethral valve, urethral atresia, stenosis, cloacal anomalies, and prune belly syndrome. And so now all of these are sort of placed together into a common ultrasound finding, which is ludo, which is an obstruction. And what we see on ultrasound are the sequelae. And what you're seeing here is a gross histology and actually an H&E stain of a dilated kidney on the bottom here. You can see the cortex is very thin and the collecting area is quite dilated. And so this is what ludo looks like on ultrasound. And this is a first trimester scan. And you don't need to be an ultrasound expert to realize that that giant black circle inside the fetus is a giant abnormality. And that's actually the very, very dilated bladder. And when you look at the image on the upper right, and you can compare the size of that circle next to the size of that fetus, you can see how significant this abnormality can be when there's a complete obstruction. And in the image on the lower right, the ultrasound image, you can see that even at this 12-week ultrasound, the kidneys are quite dilated, and we never see this degree of amniotic fluid within the kidneys. And so ludo complicates about 1 in 2,000 pregnancies. When there's severe ludo, there's complete anhydramnios by 20 weeks gestation. And this disease that is driven by very, very small abnormalities in the bladder outlet has an associated 80% mortality risk, predominantly from pulmonary immaturity. And so over 30 years ago, people have thought about developing these vesico-amniotic shunts. So these are catheters that are placed within the fetal bladder in order to bypass the obstruction. So the kidneys produce the urine gets to the bladder, and instead of coming out of the normal route, this catheter, which is placed between the bladder and the amniotic cavity, then diverts urine and sort of fills up the cavity with fetal urine, as would normally happen. And so over time, the idea is to increase amniotic fluid, decrease pulmonary compression. Maybe there's a benefit on the genitourinary system, it's unclear, and maybe an improvement in renal morbidity. And there have been several studies that have shown that that is not necessarily the case. These are the two most common historic shunts used in the US. And I say historic because the shunt on the left, which was actually developed in Europe, called the Rocket, or invented by Charles Rodick, or the Rodick shunt, has not been in use over the last couple of years because of manufacturing issues related to the shunt. But the Rocket shunt, or the Rodick shunt, is a little larger, not because I zoomed in on the image, but actually it is a little larger. And you see both of these shunts are sort of pigtail catheters with an opening at each end. You can see the trocar that is necessary for the Rocket on the left. This needs to obviously traverse the maternal skin, soft tissue, uterus, sometimes placenta, amniotic fluid, fetal skin, fetal abdomen into the bladder. And the same with the Harrison or Cook shunt, the Harrison named after Michael Harrison, who developed this at UCSF on the back of a napkin, apparently, and Cook, the company, just took that drawing and ran with it. That was the regulatory landscape 30 years ago. I can tell you today it's quite different, as you'll see in the remainder of the presentation. But similar to the Rocket trocar, you also have a sharp trocar in order to introduce the Harrison. It is slightly smaller. The rocket is about an 8 French. The Harrison is about a 5 French. But you can see that these sharp instruments can cause issues both for the mother and the fetus. But we still use certainly the Harrison today. One more just point of clarification, that while these shunts were used or developed for the treatment of ludo, they're also used technically off-label for the treatment of pleural effusion and large multicystic lung masses, and under an FDA approval and local IRB approval. So, but they were not designed for that purpose. And this is what it looks like. So the image on the left, you can see the trocar going into the bladder. In the middle, you can see the shunt being deployed within the fetal bladder there. And then the image on the right is the shunt within the bladder. And what I want to highlight are a couple of things here on the image on the right. First of all, you can see that once the bladder is deployed, once the shunt is deployed, the bladder is quite thick-walled and decompressed. That's number one. Number two is, while you can see the part of the shunt that is in the bladder, it's very hard to see where exactly it traverses the fetus and the outer part of the shunt. And so a lot of times when we deploy these, it really takes sort of a little bit of experience and a lot of moving the ultrasound probe to see the shunt in its entirety, both the inner part and the outer part. And that's very important when you're trying to determine accurate deployment. Nothing, of course, that is good is risk-free. Starting with maternal issues, we perform these in an operating room setting with sterile technique and antibiotics, using ultrasound guidance to avoid vessels if possible. Fetal trauma, certainly you do enough of these, you get complications. A lot of times we perform these before 20 weeks or around 20 weeks, where structures are quite near each other, especially when we're talking about deploying this for pleural effusion or chest masses. Obviously, there are important obstetric complications to consider, but really the Achilles heel of existing shunts are these the inherent risk of shunt dislodgement. And the issue is that if you have a high shunt dislodgement risk over the course of the pregnancy, as high as 50%, in some studies close to 80%, certainly with the Cook catheter, which is less firm. The way we counsel our patients is not just about the maternal, fetal, and obstetric risk, but we counsel them that the procedure is not a one and done, that there's a very, very high chance of needing to perform multiple shunt placements over the course of the pregnancy. And we follow these pregnancies very closely with ultrasound. And so all of those risks, the maternal risk, the fetal, the obstetric, is for a single procedure. And as you need to perform a second or third or a fourth, those accumulate. And it's certainly the risk of preterm labor and PPROM and earlier delivery. So placing these shunts is more of a marathon than a sprint. And certainly doesn't help with making the diagnosis, meaning we still don't necessarily know whether the ludo is caused by a posterior urethral valve or atresia or stenosis. And so therefore, people have thought about maybe performing fetal cystoscopy is the answer, maybe putting in a scope in the fetal bladder where you can actually visualize, and this is an image. I know our urogynecology colleagues are used to dealing with this, but for those of you who are not, this is a fetal cystoscope that is in the fetal bladder, and somebody's looking at the urethra from the inside, and they can see the posterior urethral valve here. And the idea was to place a laser fiber through the cystoscope in order to coagulate this membrane. And there was a study now, or a paper, or several papers from almost 10 years ago. By the way, Nicolas Sananas will be speaking at the next Dunleavy presentation in March, putting a plug for Nicolas. But anyway, people were quite excited about this, and this idea that you can actually put a scope, make a diagnosis, and if it's a posterior urethral valve, you laser. But then what they started seeing are these horrible complications, including these fistulas from the bladder, because it turns out that when you use heat in a very small fetus, it's not exactly a precise science. And subsequent papers have shown using MRI, and this is from a group in Paris, that essentially the angles are so challenging that to get a fetal cystoscope through the maternal abdomen and the fetal abdomen, and then have the right angle to the bladder outlet is quite challenging, and there's a couple of groups around the world trying to optimize fetal cystoscopy to improve this, but it's not quite ready for prime time, and so we're left with our fetal shunts. We've been talking about the morbidity and mortality on the individual level, but certainly there are cost implications here. And so when we combine NICU care, certainly related to prematurity, and long-term renal failure care, which includes not only dialysis but transplant, the numbers start to add up. Now, remember, I showed you that the bladder contracts once you place the shunt, and that in utero bladder dysfunction not only affects the kidney that is currently in, or the developing kidney that is certainly in place, but these children, once they undergo a renal transplant at age, whether it's 2 or 3 or 4 or 5, whatever it might be, the dysfunctional bladder actually adversely affects the new kidney that is transplanted because you have backwards flow of urine. So this bladder dysfunction, put a pin in it for now, is an important part of the disease as well. So this was a patient that we had several years ago, and when we told her about the new shunt that we're developing, hopefully you can hear the sound.
While I was pregnant with Caleb, he received 5 separate shunt placement surgeries in order to save his life. And because of the shunt, we believe that that is the reason Caleb is here today and has life. And we are really excited to hear about this new design and how it can help so many other kids just like Caleb.
So this was Mandy and Caleb, and you can see obviously a lot of pre-COVID hairstyles, and we're all smiling here. But Caleb certainly required multiple shunts and ended up getting a kidney transplant, obviously alive and still under the care of the Packard family. And she still comes periodically to visit us in the PDC when they show up. But clearly there's a significant clinical need to optimize these shunts. And so about 4 years ago, I was invited to join this multidisciplinary group that got together to try to develop a novel shunt. And it was sort of mediated by James Wall, who some of you might know. James is a pediatric surgeon who trained at UCSF with Mike Harrison, came here and started to sort of spearhead the what originally was a pediatric biodesign section and now has expanded to a maternal fetal pediatric subsection of the biodesign program. And James was friendly with Eric Johnson, his sort of neighbor in Woodside, who's a bioengineer and has helped several endeavors that have come out of Stanford. And then Kuhn Sheth is a pediatric urologist who joined this group about 6 months after she came from Texas Children's. Myself and Enrico Danzer, who was at the time he was a ped surgery fellow and has since moved on to Memorial Sloan Kettering to perform pediatric oncological surgery. So this group got together over several meetings to try to come up with a novel design and see if we can get to a prototype and then test it. And so this was the original sort of design of what ended up being called the Vortex shunt. And you can see the anchors are no longer the pigtail catheters, the original, but rather nitinol umbrella type anchors. And the original anchors were actually off the shelf ASD closure devices. And so the idea is that you have a more robust anchor using nitinol, which is the same material for other implantable devices in humans. So nothing here is something that has not been implanted in a human before. And the idea is to create sort of a sneb between those two anchors that can stretch and kink and twist as the fetus is developing. The other important development of the Vortex shunt was to create or insert a one-way sort of duckbill valve that will only open once a certain pressure is achieved within the bladder. And the idea is to hopefully, by using the duckbill valve, improve bladder cycling once the shunt is inserted. So the thinking is, if we can insert a shunt with stronger anchors, we'll have less dysfunction. And if we can create this sort of stem between it that can kink and twist and turn, it can accommodate a growing fetus without being dislodged. And if we can insert this duckbill valve, we can then address the bladder dysfunction that happens with existing shunts. And so initially we performed benchtop testing in Eric's garage in Woodside, and using this sort of pull force machine here on the left, you can see the pull force that it requires to pull these shunts out of a Porkin bladder. So Eric developed this sort of benchtop model that has a pig bladder attached to, as you'll see, is very rudimentary, but actually quite simple and efficient, where you can test the pull force of what it would take to pull. And you can see the Vortex shunt requires the most force. Now, what I want to show you is how low tech this initial model was, but it's so similar to the human. What you're seeing is the ultrasound on the right of this Porkin bladder, and we're placing this into using this very rudimentary system. But I want to show you this video again, and just to highlight how real. So this looks just like the real bladder, and here's the shunt that is deployed. You can see it looks just like the shunt that we do in humans. And the important thing, the important thing here is that once it's deployed, you can see how visible the shunt is on both sides. And I'm sorry, it's not quite working. Then when we extend or bend the Vortex shunt, you can see that it achieves what we want from a technical specification perspective, especially since when we insert it, it's not like we exactly have the optimal spot in the fetus. We're limited by the position and other things, and it's not exactly placed always in the same spot, certainly not in the lung. And so this becomes quite important in terms of reducing dislodgement risk. And then we perform some benchtop testing of the one-way valve, and you can actually pick the kind of valve that you want to place in here. And it turns out that the opening pressure for this valve that fit nicely into the Vortex shunt mimics the opening pressure within a neonatal bladder. And so we think that we have the right specifications for this particular valve. And so we published our preliminary data of the development of the Vortex shunt and the benchtop specifications about a year and a half ago now, or about 2 years ago now. And you can find it there. Over time, rather than taking ASD closure devices and pulling them off the shelf or breaking them apart and attaching them to a stem, we've been able to receive research funding and actually create everything from scratch ourselves, i.e. Eric in his garage. And so now we can control the specifications of the anchors. We can attach it more securely. It starts to look more like a medical device. There's a sterile steel end that we can then trim, and we can actually start to control the size and the width and all the other specifications to test it in different systems. And you can start to see the difference between the 1.0 version and the 2.0 version. The other important improvement that we think we've made is the delivery system of the Vortex shunt mimics a IVC filter deployment rather than a fetal shunt deployment. So the shunt is then inserted into a canister, and then you have essentially an introducer sheath that is 7 French. So it's, in terms of the size, it's somewhere between the Cook and the Rodic. And by having this sort of 3-way stopcock in the sheath, then when you insert the trocar, you don't have extravasation of the urine from the bladder. And I know it's a little technical, but this is an important aspect of deploying the shunt, where you have some time to insert it appropriately. And so we went back to benchtop testing with a 2.0 shunt, and this time not just Porkin bladder, but actually other sort of models. And you can see pretty low tech, but pretty efficient for testing the expansion and the kinking and the twisting, and that's very, very important. And once we could manufacture these ourselves, you can manufacture them in different sizes, both in terms of the trocar sizes and in terms of the sizes and the length. And that's important both in terms of the gestational age that they might be deployed in, or whether it's going to go into the lung or the bladder. You might want to have different sizes with different specifications. So it's not a one-size-fit-all shunt, but rather it'll come in different sizes. And so as we were performing these preclinical studies, I guess you can call them, in the benchtop, the machine on the left, you can see the kinking that happens with the rocket shunt versus our shunt. We started to think about, okay, is there an animal model that we can now assess our shunt in. And many studies, as almost everybody on this webinar knows, many studies in obstetrics were historically performed in sheep as an animal model. And so we started calling around colleagues that had sheep labs around the United States. And a lot of these labs weren't necessarily interested in Ludo, or it was going to become very, very cost prohibitive. But luckily, there's a group in Leuven, Belgium, that is under the direction of a very prominent fetal therapy expert named Jan de Prest. And one of our colleagues, Enrico Danzer, had a very close, and still does, a very close relationship with Jan de Prest group. And it turns out that the Leuven group was interested in understanding the pathophysiology of Ludo and had been performing these experiments in Ludo in order to understand why it is that anhydramnios leads to pulmonary immaturity, understanding the effects of Ludo on the developing kidney and bladder from a biological standpoint. And so it was very fortuitous that one of the most prominent fetal therapy specialists with one of the best labs in the world just happened to have the only sheep Ludo model in the world. And one of our group members had a close relationship with them. And so obviously we contacted them and said, look, you're interested in Ludo, we're interested in Ludo, you have the sheep, we have the shunt, can we please collaborate? And so what you're seeing here is the way that the model is created. So a sheep gestation is about 140 to 150 days. So they create the surgical model at 70 days. They open the sheep uterus and expose the fetus and create this in both males and females. And then you can see that by the third trimester equivalent in the sheep, you have a megacystis, so you have an enlarged bladder. You can see hydronephrotic kidneys. And so this mimics the human pathology very, very nicely. And so Enrico flew over there almost a year and a half ago, and this was our initial feasibility study, or the first time we deployed it. And this was at full term, and so this was at 135, 140 days. And what you're seeing, again, highlighting how well the shunt can be seen in both its distal and proximal part, including the stem all the way here. And we were very, very excited when Enrico sent us these pictures. What you're seeing here is the fetal bladder that is now decompressed with the part of the shunt that is in there. You can see how beautiful, you can see the entire shunt all the way to the skin, and you can see the urine coming out of here. And these were our initial studies back in July 2022. And so this sort of really validated what we wanted to do next, which was now perform these early feasibility studies, meaning can we deploy these shunts in this Ludo model at any gestational age? So I showed you the Ludo at full term, and this was the percutaneous deployment of the shunt into the fetal chest. The pleural effusion model was created simply by injecting fluid into the fetal chest just to simulate what a pleural effusion would look like. And you can see that at full term, this was at 135 or 140 days. These shunts were deployed successfully. And you can see it again now, how beautiful you can see it in both the proximal distal part. You're no longer squinting your eyes to try to get a sense. And it's because this nitinol that links both those anchors just literally lights up like a Christmas tree on ultrasound. And so immediately after deploying these sheep or ewes were harvested just to validate the deployment. And on the left, you can see this is the Ludo one with the outer part here, the inner part in the bladder, and this was the chest part. And so our initial studies were deploying the shunt both in the lung and in the bladder at full term once the model was created, and harvesting them immediately after. So over time, during the course of the summer and the spring, Eric really progressed in terms of the manufacturing and started getting components from different vendors and really designing and developing these himself and optimizing the prototype. And you can see you can then package them individually and sterilely to make it look like an actual medical device. And so the part on the left is our different shunts. These are different sheets. These are the sharp introducing trocars. And so we started taking these with us to Leuven over the next subsequent months. And so our next thinking was, okay, we've shown that we can deploy these at the end of gestation. Can we deploy them at what would be considered similar gestation of the human, around the early part of the third trimester? And so again, the luteal is created at 77 days. And here we are 4 weeks post-luteal, not quite at full term anymore, but really sort of in the third trimester. And you can see these hydronephrotic kidneys. You can see the dilated bladder. Invariably, there's a little bit of extravasation of the urine into the abdomen. So this is urinary ascites, which we sometimes see in the human as well. And so these were our feasibility now in the third trimester. You can see the introducer sheath over here going into the bladder, and you can now see the shunt being deployed in the third trimester equivalent. This is the fetal bladder. This is the amniotic fluid. And you can see how well you can see the shunt across both sides under ultrasound deployment. So now we've shown that not only can we deploy it at full term, we can actually deploy it at gestational age equivalents to the humans. And then we waited 24 hours. So this is a shunt that's 24 hours after deployment. So we wanted to wait at least a day to see if it's still there, because a lot of dislodgement happens within the first day. And you can see that 24 hours post-deployment in all of our animals, the shunts were still in place. There was continuous drainage, improvement in the urinary ascites, and amniotic fluid present. And so instead of harvesting them immediately as we did in the first feasibility studies, we now waited a day. And what you're seeing here on the left is the ultrasound picture between the bladder and the amniotic fluid. And this is 24 hours after deployment. You can see that one part of the shunt is within the bladder and the other part is within the skin. And so this was obviously no dislodgement within 24 hours and no injury to nearby anatomical structures. And then the bladder, the kidneys, and the lungs were all harvested, and there's still ongoing analyses of these in Leuven, looking at the structures of interest. So it's not just about dislodgement, but we want to see and make sure that there is appropriate effect on the organs of interest here. This is a similar deployment that you can see here on the ultrasound for the pleural effusion model. Same thing, we deployed it within the developing lung. We had accurate deployment of the handful of cases. And then 24 hours later, again, we saw no dislodgement. And you can see this is the harvested lamb, where you can see the shunt within the chest. So this, we're looking from below, and you can see the outer part and the inner part appropriately placed in the pleural effusion model as well. And so recently we published this next sort of iteration of our Vortex shunt in prenatal diagnosis, and you can read more about it there. And so really, after showing that we could deploy this at full term and that we can deploy this at mid-gestation, really what everyone wants to know is, how long will it remain in place? What if you deployed it in the early third trimester equivalent? Will it stay 4, 5, 6 weeks? And also, what will be the effect on the developing lung, bladder, and kidneys? And those studies are ongoing now. I'm heading back to Leuven in March, and we're looking at additional dates in the summer. And hopefully I have answers for you for these very important questions within the next 6 to 12 months. In terms of the cost benefit potential here, this was an analysis by a med student from NYU, Jamie, who reached out to Kunj and said, hey, I have an interest in biodesign. Do you have a project for me? So Kunj said, yeah, we have a project for you. We're interested in analyzing the potential cost benefits on a societal level. And so we linked up with Aaron Coy, who many people know here, and Claire, who is one of his outstanding trainees, who's now at Harvard. And essentially, we wanted to create this sort of tree schematic of, if we could improve dislodgement from 50% to, let's say, around 10%, what would be the cost savings potentially on end-stage renal disease or neurodevelopmental outcomes, because you have less prematurity and less end-stage renal disease. And what we've shown was that if we had a model of 1,000 luteal pregnancies, and if we could reduce dislodgement from 50% to a 10% theoretical case, we could result in 60 fewer cases of end-stage renal disease and 10 fewer children with neurodevelopmental outcomes out of 1,000 luteal pregnancies. And you can see the cost savings there. And we ran similar analyses if we can reduce the dislodgement from 50 to 40 or 30 or 20 with similar both clinical and cost benefits. Obviously, these are all theoretical. Now, just to give you an idea in terms of the 1,000 Ludo cases, right now in the United States, there's approximately 200 of these shunts being placed annually. Now, because of the dislodgement risk, the shunt is only offered to the most severe cases because the risk benefit calculus in terms of the risk of dislodgement and PPROM and maternal morbidity doesn't favor, for the most part, inserting these shunts in partial obstructed cases, meaning cases where you see an enlarged bladder but normal fluid. But what we've seen from data that's been published over the last 2 to 3 years is that even in cases where Ludo is partial and there's still amniotic fluid, even though there's a higher survival rate from a pulmonary perspective in these neonates, there's still quite a significant end-stage renal disease in those cases. And so what we're thinking is that if we can optimize the shunt from its dislodgement risk perspective, the shunt might be offered to a greater number of Ludo cases because there may be an improvement in end-stage renal disease. And so there's more to be studied there. Obviously, to get to where we've gotten takes some funding or a lot of funding. And I want to just thank and highlight the Dunleavy program that provided us with $35,000. And you can see the other funding sources here, predominantly funding sources within the Stanford community. And I wanted to highlight this, not to sort of pat ourselves on the back and say, oh, look how much money we received, but just to highlight the kind of sources that would be available for people on this webinar who might be interested in biodesign or medical product design. And so there's quite a bit of resources here to get you to a working prototype and maybe even an animal model, which is great. But just to give you an idea of what it would take to get to actually in human studies, we're here in 2023, early 2024. So we've gotten about $400,000. We have a Ludo animal. Now we're in 2024, and you can see that the number of funding that we need to get is probably about $1 million. And it's not so that we can, do more animal studies or start to pay ourselves a salary or anything like that, but really a lot of validation and verification, a lot of engineering costs are really here. And so it's quite a large cliff to try to get to $1 million. And then eventually you get to something like a $3 million cliff that includes, first in human studies and other things. So right now we've submitted a proposal to the FDA just to make sure, it's called a pre-submission to the FDA, where we want to make sure that our animal models are in line with what it would take to get to a first in human clinical study. Once we get approval from them, the idea is to sort of perform these animal studies under sort of more closer observation by the FDA. And hopefully we can get this kind of funding over time to get us to commercialization. Now, I was telling you initially that nobody's going to gain significant wealth. So if you do a back of the envelope calculation, you say, okay, 200 cases a year, and there's only so much you can start charge per shunt, and you need this kind of money. All of a sudden, you realize very quickly that no venture capital firm is ever going to fund this. And you have to start going to other sources and people who might just be interested from sort of a passion project in order to save human lives. And so what we've started to do is look at, we've certainly applied to the Stanford Catalyst program, which is great. And we're one of the finalists waiting to hear back. There are several large philanthropic cases. Certainly, we've been partnering with a Packard Foundation to spread the word that we are interested in this and where we've gone. And we've recently submitted a small business grant from the NIH, and there's also an opportunity to do an SBIR grant from the NSF to try to develop this. But ultimately, we would need to partner with a strategic that is either already in the fetal space or interested in entering, because even if we can get that 1 to 3 million from one of these sources on the left, and even if we get to a first in human study, and even if it's successful, and even if we can prove that it's efficacious, none of us on that slide that listed the 5 of us is ever going to do this as a company and start to distribute it within the United States or outside. And so you would need to have this thing sort of picked up by a company that incorporates it into the portfolio. And so we've started some preliminary discussions with them to see if anybody's interested, but it's very, very hard to get a company that, especially in the macroeconomic climate, and you say, look, this is going to save 100 to 200 lives, and you're going to lose money on every shunt, which they will. So we're trying to play that that argument, and hopefully we're successful. So we're really operating on several fronts. I spoke a little bit about the biodesign program, and I want to just highlight that within the biodesign program, the maternal, fetal, and pediatric slice of that is now called Impact One. It's a phenomenal program for potential innovators, people who are interested. It's mostly educational. I think Eric Sokol was in it. There might have been some other folks. Well, he was in biodesign before there was Impact One. But there are opportunities to be involved with this, and there's actually a maternal, not a fetal, not a pediatric, really a maternal pitch competition that's going to happen at Stanford on April 23rd. I know that Yair was a judge on the previous one last year. Applications are due March 20th. If somebody has, it doesn't even need to be a full-fledged company. It could be 2 potential innovators and a prototype, or anybody who is slightly more advanced, but it needs to be an early stage product with less than $2 million in private or any other financing. And it's a great sort of group that gets together some investors, a lot of innovators, faculty to review, and it's actually open to the public, and so you're welcome to come, and it's usually held at Li Ka-shing. And so our next steps for Vortex in 2024, we're doing some MRI compatibility studies to see whether the Vortex shunt could withstand an MRI. And so not because you need to perform an MRI, but a lot of times we do that in a clinical setting. Again, we are embarking on clinical efficacy studies in the animal model. So we're doing this now in the summer. As I said, we started FDA discussions to see what it would take to get the first in human studies, discussion with potential partners. Again, the funding, we hope to hear within the next 6 months about a decision. And really, I'd love to pick anybody's brain. You don't need to be in OB or MFM. Hopefully what I said resonates with you. I'd love to show you our shunt. I'm happy to show you our shunt. Love to hear any ideas you might have, because we're obviously still in the iteration phase. And so I'll stop here. I'm happy to answer any questions, and thank you for giving me the opportunity to present. Looking at Ron Gibbs. Oh, thank you, Ron. I don't know if I'm supposed to be the one reading these, but thank you. Eric, great. Love to chat with you as well, Eric. Just reach out to me. Okay. I guess if nobody has any questions, we'll start our clinical day. Thanks, everyone. Yakin, I'm just going to leave.
Okay. Thank you.
Bye.